The indications for performing an EZ-IO in an adult patient in cardiac arrest are that ideally we would like you to attempt a peripheral site first or an EJV. Having been unsuccessful, you're then permitted to attempt an EZ-IO. If, having said that, trying to get a cannula or an EJV would delay treatment because of other interventions going on at the cardiac arrest, you are permitted to go for an EZ-IO attempt first, so long as you document why. For a paediatric in cardiac arrest, EZ-IO drug route is our first port of call, so it is not necessary to attempt peripheral cannulations first. In an adult or a paediatric who isn't in cardiac arrest but is severely injured or ill and requires urgent drug or fluid therapy, we are permitted to undertake an EZ-IO. However, we must have attempted and failed at least 2 peripheral IV attempts first. It's worth noting that if undertaking an EZ-IO in an adult or a paediatric who isn't in cardiac arrest, they are likely to have a very low level of consciousness and no pain response. The contraindications for performing an EZ-IO are if the patient has a prosthesis, if there is a scar over the joint, if there is a fracture in the target bone, if they've had an EZ-IO performed in that bone within the last 24 hours, if you're unable to locate the landmarks, or if there is an infection at that site. The 4 rights for EZ-IO are the right site, the right needle, the right flush, and the right aftercare. The right site will either be the proximal humerus, the proximal tibia, or the distal tibia. The proximal humerus has the benefit of delivering a slightly faster flow rate for our drugs or fluid. The proximal tibia is the site that we should be using in paediatric patients. We are able to use different sites in paediatric patients. However, because of the difficulty in locating the landmarks on peds, it is a preference to use the proximal tibia site. And if you go away from this, it's important that you document why. The right needle, we have 3 sizes of EZ-IO needle. We have a red 15mm in length needle. We have a blue 25mm long needle, and we have a yellow 45mm long needle. The yellow needle must be used for adult patients where we are attempting an EZ-IO in the proximal humerus site. Aside from that, your choice of needle will depend on the site that you've picked and how fleshy you deem that site to be. The right flush involves flushing any drugs or fluid through the EZ-IO port using a giving set, a syringe, and a 3-way tap. It's important that we deliver our fluids and our drugs using a syringe and a 3-way tap because the pressure within the bone medullary capsule is high. So we need to ensure that we are delivering our fluids and our drugs with some pressure in order to get them through that medullary cavity and into the vascular space. The right aftercare involves us paying close attention to the site, keeping an eye for any signs of tissuing or any signs that the site may not be patent. If the needle becomes dislodged, removing the needle and making sure that we attach our pink wristband onto the patient once we have either attempted or successfully gained our EasyIO port. Before we undertake the EasyIO, it's important that we get our fluid and our giving set primed and ready to go. So I will have already cross-checked my bag of sodium chloride with a colleague to make sure that it's in date and it hasn't been tampered with. I will have then asked my colleague or myself will have primed the giving set, making sure that there is no air bubbles in the line. Then I want to connect it to my right angle connector and my 3-way tap. So being careful not to touch the key parts of this equipment, I'm going to attach the 3-way tap by pressing and twisting the ends together. I will then attach this to the end of the giving set, again being careful not to touch the key parts. The third element of connection is my syringe. It's very important that I prime my right angle connector to make sure that there's no air within the tubing. In order to do that, I'm initially going to turn the port of the EasyIO off to the right angle connector, turn my fluids on, and draw up some fluid into my syringe. I can then direct my 3-way tap around to the angle connector and prime that with fluid. The most important thing here is to make sure there's no air in the set. So if there is air, that's okay. We'll just draw up a little bit more fluid and then remove the bubble from the syringe. And I'm satisfied now that there is no air anywhere along this line in the 3-way tap, within the right angle connector or within the syringe. So that's primed and ready to go. Now I want to locate my site. So when measuring the sites, the first option we have is the proximal humerus. So in order to find the site here, it's very important that I adduct the arm. So I'm going to put the hand on the patient's belly button and tuck the elbow in. And that will allow the humeral bone to become prominent. And you might need a crewmate to assist you with this. I'm going to run my thumb up the patient's arm until I feel a change in direction on the bone. This is the surgical head of the humerus. 1 centimetre above that is the greater tubercle of the humerus, and this is my proximal humerus site. Alternatively, I've got my proximal tibia site. And to locate the proximal tibia site, I find the patient's patella. I come 2 centimetres below that, where I can feel the tibial tuberosity. Coming 2 centimetres medially to this is my site for the proximal tibia. The third option that I have is the distal tibia. To locate this site, I will find the medial malleolus, so the prominent ankle bone on the inside of the patient's leg, and come 3 centimetres up the tibia, still on the inside of the leg, and this is where my distal tibia site is. So once I've primed my equipment, I've located the site on the patient that I'm going to go for, I can then go ahead and perform the procedure. So I've already found my site. I'm going to clean my hands. And don my gloves. Having found my site and assessed the tissue around the site, I can then gauge which length of needle I'm likely to need. And so for this site, and given the amount of flesh here, I'm going to opt to use the blue 25mm needle. I'm going to clean my site using a chlorhexidine. Which I'll then pop into the sharps. So I've checked my needle, I've checked that it's in date, and I can connect it to the drill using the magnet. I'm going to puncture the site with the needle until I feel bone. Then I'm going to have a look to make sure I've got at least one black line visible. Having one black line visible means that I know that I've got some clearance to get through the site and into the medullary cavity. Being satisfied that there's at least one of those black lines there, I'm then going to drill in a smooth fashion until I feel a give. And I can remove my drill. Checking that that needle is firmly in place, I'm going to hold the bottom and unscrew the top, removing the needle, putting it straight into the sharps bin, leaving the catheter in sight. I'm then going to attach my dressing. Attaching my right angle connector to the catheter just requires screwing onto the top, and then checking that my three-way tap is directed to the syringe and to the Ezio and not to the bag of fluids. I can then withdraw some space on my syringe, and hopefully I will see some bone marrow, which is a nice confirmation that I've sighted my Ezio correctly. And that bone marrow will look like a straw-coloured fluid, maybe with some specks of blood in it. If I don't get any bone marrow, I'm still going to attempt to flush the site, just being mindful that perhaps I haven't placed it properly. So I'm going to go ahead and flush my site with 10 mils of saline for an adult or 5 mils for a child. When I'm happy that that has flushed through, I've checked the site, there's no obvious tissuing or swelling, I can go ahead and use my Ezio port. Remove my gloves, clean my hands, and document the time and date on the wristband and attach it to the patient. And then complete my PRF. After performing the Ezio and throughout its use, it's important to keep an eye on the site to make sure that it isn't tissue and that your drugs are still flushing through properly. If the needle does become dislodged, it's important to then remove that needle and cover the site over with a dressing, making sure that you hand this over to any hospital staff or any other receiving clinicians.